welcome to another video in Foundations of Maternal and Newborn Health. In today's video, we're going to be talking about postpartum hemorrhage. This is also known as PPH. And postpartum hemorrhage is defined as more than 500 milliliters or half a liter of lost blood after a vaginal delivery. And so this is actually a liter after a C-section, but this is that's less important for us. So today we're going to be talking about the possible mechanisms of postpartum hemorrhage. And there's what's known as the 4 T's. The four T's of postpartum hemorrhage, of PPH. So the first is, and most common, is tone. So tone is muscle tone. So kind of the contractibility, the ability of the muscles in your body to contract. And specifically we're talking about uterine tone. And so there's a disease known as uterine atony. And this is when the uterus becomes too tired to contract properly. And so after delivery, the uterus needs to contract to actually stop bleeding. So the uterus contracts to stop bleeding. So the second one we'll talk about is trauma. And so this is usually damage to the vaginal canal or even to the uterus itself. So these are also known as lacerations. You can also think of these as cuts. So that one's pretty straightforward. If there's trauma to the vaginal canal for whatever reason, there's going to be extra bleeding. The third one is tissue. And specifically when we're talking about tissue, we're talking about a retained placenta. And we talked about retained placentas in the placenta creta spectrum disorders. But if there's leftover placenta left inside of the uterus, it stops it from contracting properly, and it also keeps a site open for bleeding to happen. And then the last one is thrombin. And so hopefully you've watched the clotting video, and thrombin is a clotting factor. So we didn't talk about thrombin specifically, but we talked about clotting factors. And thrombin is one of these clotting factors, one of the most important clotting factors. And so if you have an issue with clotting, with clotting, then you can have really bad postpartum hemorrhage because your body can't maintain hemostasis. It can't stop bleeding because your body can't form clots properly. And so even though thrombin's used to remember the issue with clotting, it doesn't necessarily have to be an issue with thrombin. It can be an issue with a variety of different clotting factors or other issues that cause problems with clotting. And so they're called the 4 T's, of course, because all of these start with a T to help you remember that all of these different things can lead to postpartum hemorrhage. And the reason why it's important to understand these mechanisms is because each of these mechanisms that cause postpartum hemorrhage have different treatments. And so if you have a woman who has an issue with a retained placenta, giving a treatment for trauma or thrombin won't necessarily fix this problem, and she may continue to bleed. And so it's important to identify which one of these issues is actually causing the postpartum hemorrhage. So for tone, there's a special class of medication known as uterotonics. And these are drugs that improve the tone of the uterus. So tonics for tone and utero for uterus. And so these include drugs like oxytocin, misoprostol. I'll just put Meso-P for misoprostol, ergot, Hemabate. And all of these do the similar thing. They all cause the uterus to contract. And so if the uterus is too tired or it's not getting a strong enough signal to contract to stop bleeding, you can give uterotonics that may help the uterus contract and stop the bleeding. If there's a laceration, of course, giving uterotonics won't necessarily help. The laceration or the cut has to be repaired, so a repair needs to be done. For retained placentas, you have to actually remove the placenta that's left in the uterus, so manual removal. There are other treatments for retained placenta, but for our purposes, manual removal will be the most common, the most used. And for a note for this, if a placenta has not been delivered within 15 minutes of birth, then the woman's at 3 times more risk of postpartum hemorrhage, of losing more than 500 mils of blood. And then if it's been 30 minutes since delivering the baby and the placenta is still inside, this is a big issue and you need to call for help. Call for help ASAP. Because this woman, there may be some bigger issues at play. The placenta, it may be a PAS placenta or a placenta accreta spectrum disorder, but this placenta needs to come out. And if it's been 30 minutes, she's at risk of a lot of issues. If it's an issue with clotting, then you need to give clotting factors. And this is the least likely to be the cause of postpartum hemorrhage, but it's important to be aware of and which blood tests you should be running to actually identify whether this is an issue. And so there's even an example of other drugs that can help with this as well. So not necessarily just clotting factors, but also something known as TXA, which is tranexamic acid. And this stops clot breakdown. And so these treatments aren't necessarily independent of each other. For example, you may give TXA even if there's an issue with tone or if there's an issue with a laceration. So this is indicated for other forms of postpartum hemorrhage, but it's really targeting this clotting factor pathway or issues with the clotting factor pathway, and that's why we give it. The last thing that I wanted to talk about is high-risk patients. So really, although all of these mechanisms can be at play in any patient, there are patients that you can try to flag or be aware of maybe at risk of postpartum hemorrhage or at risk of, decompensating quickly if they do have a postpartum hemorrhage. And so things like anemic patients. So we talked about anemia in a previous video, but anemia is low red blood cell count. And so if a patient doesn't have many red blood cells, even a little bit of postpartum hemorrhage bleeding will cause this patient to have a lot of issues because their body doesn't have a lot of red blood cells to rely on. And so if they lose even a little bit of blood, they may decompensate. They may have bigger issues very quickly. things like prolonged labor. So if a woman has a really long labor time, then the uterus is at much higher risk of uterine atony. The uterus is much more likely to fatigue and not be able to contract because it's been working for a really, really long time. And so if you have a really prolonged labor, you should start thinking about postpartum hemorrhage. Maybe there's a higher risk. We should be prepared, kind of setting up for success for a potential postpartum hemorrhage. A more unique case is a family history of bleeding disorders. And ideally you would know if your patient has a bleeding disorder before taking them on for care or before having them deliver in a rural setting. But if a patient does have a family history of bleeding disorders, can't be tested, or has come in for labor, last minute with no prenatal care, then again, this would be another one where it's good to be prepared in advance, because if they do have a bleeding disorder, they have issues with clotting factors, and they will most likely have a postpartum hemorrhage. So this was a lot of information, but hopefully this makes sense that there are different mechanisms for postpartum hemorrhage, and there are different treatment options depending on which of these mechanisms is at play causing the postpartum hemorrhage.